Hi, welcome to CNS Pharmacology Part 2. We're going to cover a little bit about pathophys and pharmacology for Parkinson's, Alzheimer's, multiple sclerosis, and epilepsy, focusing on some muscle spasm and spasticity drugs. So just general overview, we know with CNS drugs that there's this period of time it's going to take for the medications to be effective, sometimes days and sometimes weeks or even months. So the patient's going to have to be tolerant about the adverse effects until this drug really starts to become effective. We know that the adverse effects can be pretty bad at the beginning of this too. So, and as this uh, drug starts to be effective within the months, days to months, the adverse effects will start to decrease. So there's a lot of teaching to do with that so that people don't become frustrated. Some people also will have that tolerance that will build up, and some of these drugs lead to physical dependence. So, got to bear those factors in mind on all these drugs. We learned, or you should have learned some of this with the CNS Part 1, and know that a really important thing to remember is not to stop these medications abruptly. So, just a general overview. Okay, so we're going to start with Parkinson's disease, and we got to see Michael J. Fox and Muhammad Ali. They're going to be in our little discussion here in a minute. So here's the objectives: to identify most common degenerative diseases of the central nervous system, distinguish between idiopathic Parkinson and secondary Parkinson disease, describe the symptoms of Parkinson disease, and explain the neurochemical basis for the disease, focusing on the roles of dopamine and acetylcholine. So again, we see Parkinson's here affecting both Muhammad Ali, the boxer, and Michael J. Fox, the actor. Parkinson's is a disorder of the extrapyramidal system. So that has to do with akathisia, difficulty with movement. And so there's no cure. That's the really bad thing about this. The treatment is with drugs that are going to treat this imbalance of neurotransmitters and treat other psychiatric problems that go along with it. The onset is middle age, 40 to 70, with a peak around 60, which for this kind of progressive debilitating disease is actually sort of a young age. So back to these two, Muhammad Ali and Michael J. Fox. Idiopathic is the type Michael J. Fox has, as far as I know, where for no known reason he started with maybe some fine hand tremors and ended up leading to this diagnosis of Parkinson's. So that's the idiopathic type. With Muhammad Ali, we know that boxing is the reason, repeated blows to his head, causing damage that would be secondary type of Parkinson's. So the secondary type can also be caused by exposure to toxins, antipsychotics, where the patient can get the pseudo-Parkinson's, the extrapyramidal symptoms. And so with those, because it's a pseudo-Parkinson's, when you stop the antipsychotic, the symptoms should go away. With Parkinson's, that's not true, but with if you're just taking antipsychotics, stopping the drug helps get rid of those extrapyramidal symptoms. Okay, so this picture is right from your book, but it's a good one to show the types of debilitating physical features from Parkinson's, the shuffling gait, some of these other symptoms. The brain is there showing the parts of the brain. I'm not testing you on that, but it's showing you the lack of dopamine occurs in these areas. We want to focus on the symptoms: drooling, open mouth, hand tremors, shortened steps. All those things increase until the patient can't perform regular ADLs. So also that kind of gait and posture and tremors, this is all a big concern for fall risk with these patients. So this problem can be caused by dopamine blocking drugs or degeneration of neurons where not enough dopamine is in the synapse, and then an increase in acetylcholine or ACH leads to the lack of smooth muscle movement. The treatment is to block the ACH or to increase the dopamine and the activation of dopamine receptors. So you're either increasing dopamine or giving direct dopamine receptor agonists like pramipexole, and you see that benztropine is a ACH blocker, and so all of those things will help get more dopamine available. Right, so Parkinson's goal of therapy. We know that there is no cure, so the best thing is to restore balance of increasing dopamine and decreasing ACH and fix that imbalance. Improve uh, activity of daily living for the patient to the fullest that we can. And then it's a fine balance. You got to balance between the therapeutic effects of these drugs and the adverse effects of these drugs. Anticholinergic drugs block receptors for acetylcholine or dopaminergic agents that are going to increase the amount of dopamine available to neurons. So just going back to this picture that we had on the previous slide, you see that in the synapses there, they show how dopamine is coming across the synapse and levodopa gets processed. So that's one way to give more dopamine in there. And then you see that the cholinergic receptors looking for ACH, if they're getting blocked, then more dopamine can be there instead of ACH. And then that's about that, covering it so that you can see the different ways to increase the dopamine. I just didn't want you to forget to look at the overall picture of in the synapse. Okay, and we talked about this already. So here is a list of the drugs that we're going to look at. The dopamine replacement, levodopa, carbidopa, dopamine agonists like pramipexole or Mirapex, anticholinergic drugs, benztropine or cogentin, COMT inhibitors, entacapone or Comtan, dopamine releaser, which is amantadine or Symetril, and the MAOB inhibitors. MAOBI means it's selective for the B receptor, so it doesn't affect all the MAO in the brain, all those receptors, just the B type. This inhibits the breakdown of dopamine. Selegiline can be given by mouth or administered under the tongue sublingually. So the sublingual route is also supposed to be a reduction in side effects from the breakdown of the products of selegiline. Okay, so the primary drug for dopamine is levodopa. This provides a 50% decrease of symptoms in 75% of the patients. And this is a temporary fix because in about 5 years, the disease will not be treated well by levodopa. The brain doesn't become tolerant to it. It's just that this disease is progressive and it gets worse, and brain tissue and all, it won't be helping. It takes several months to help, and it's important to teach that time may have to pass those several months to get the good effects. And you have to put up with the side effects, knowing it will take that much time for the benefits to start. Dopamine itself cannot cross the blood-brain barrier, so levodopa is a precursor, and it's actively taken across and crosses into the blood-brain barrier, then gets metabolized to dopamine up in the brain. So an increase in dopamine in the CNS gives that increase in smoother muscle movement. So some pharmacokinetics, dopamine is metabolized in the gut and in the periphery and in the CNS. D-carboxylase is the enzyme that metabolizes the drug to dopamine. COMT is catechol O-methyltransferase, which is an enzyme, and it degrades or metabolizes dopamine and other catecholamines like epinephrine and norepinephrine. So they get metabolized to inactive metabolites. So only 1% of the levodopa actually gets to the brain. So there's two problems here that are created. You have to give a bigger dose of levodopa to get enough into the CNS. And then it's also metabolized in the periphery. So there's increased dopamine in the periphery. And that use of dopamine is the cardiac effects when it's used kind of in the periphery. Increased inotropic effects, which is force of contraction, hypo or hypertension. So those aren't the effects you're looking for with Parkinson's. So absorption is also affected and reduced if you take this with high protein meals. There's competition from amino acids for intestinal absorption. So you got to separate this drug from a high protein meal. Don't take it with a very high protein meal. It takes some teaching to get people to, make sure they're getting the most out of their levodopa. Also, there's a loss of effect from dopamine, which occurs with the proteins indirectly decreasing absorption. So, like I said, you need to not take it with a high protein meal. Okay, some adverse effects. Psychosis happens in 20% of the patients because excess dopamine in the brain causes psychosis. So this makes sense. Nausea and vomiting are early adverse effects that tend to decrease over time as you start getting the effects of the dopamine because it's going to take those weeks to months to get going. Orthostatic hypotension from peripheral dopamine. So this is important for teaching about being safe. It can also cause dyskinesia, which are abnormal movements or disabling jerking. So we already know that there's a fall risk from the shuffling gait and all of that. So now you add this jerking, and the patient's going to be really impaired overall, and that's not great, but but that's what happens. So reducing the dose may help a little bit with the disabling jerking or the dyskinesia, but then you're going to have a return of some Parkinson's syndromes. So it's a really thin line. Again, you got to really hit the balance between therapeutic effects and adverse effects. Also, there's a discoloration of urine that can happen. It's a dark color. I think it just says a dark color, dark brown or red. I don't think it's red, just dark brown. It's a discoloration that isn't harmful. It's just annoying and it can stain the clothing. So you need to teach about that. Okay, so we know that the levodopa does not get there. 1% is not a great amount. So what are we going to do? We add carbidopa to levodopa and you get Cinemet. Carbidopa is a metabolism inhibitor only. Its effect is to decrease the amount metabolized in the periphery. So when you only got 1% with carbidopa added, you get up to 10% getting into the CNS. So you really increase that. The first benefit is that you're increasing the amount of levodopa or dopamine that actually gets to the CNS, to the brain. The second benefit is you can decrease the dose because there will be more in the brain. So there's also less systemic dopamine, so the adverse effects, maybe the nausea and vomiting, are decreased there. And then carbidopa does not cross the blood-brain barrier at all. So carbidopa has nothing to do with really treating Parkinson's. It's simply a metabolism inhibitor that works in the periphery. And so you see the top arrow, how it's really a large black arrow showing how much levodopa you're giving, and then the skinny tiny arrow that goes over and shows you in the neuron how much really gets there. That's the figure for 1% getting in. And when you add the carbidopa down below at the B level, there's a smaller dose of levodopa that you're giving, and then you're decreasing the metabolism in the periphery, so you get fewer GI effects. The nausea and vomiting goes down, and you also get less of that orthostatic hypertension or cardiac effects because there's less in the periphery. And then you get a bigger dose, the 10% going into the brain itself. So it's a good way to treat the Parkinson's. Okay, so drug interactions. We know that conventional antipsychotics like Haldol block dopamine. And the result is good for psychotic symptoms, reducing the dopamine, but that's not going to help Parkinson's, where we want to increase the dopamine. So, and then why would it be different, do you think, for conventional antipsychotics versus atypical? The different antipsychotics are going to be using different dopamine receptor sites. So with the atypical, there's not as big an effect. The MAOIs increase dopamine and norepinephrine, which leads to vasoconstriction. And then we have acute loss of effect. So wearing off is one that's a gradual loss of drug levels. They're reduced between dosing. So you're taking it every 6 hours. Then it wears off at the 4 hour or the 5 hour mark, and it's not helping you as much. So shortening the interval of dosing is the way to fix this. So instead of taking it every 6 hours, you take it every 5 hours or take it every 4 hours. And this one we can fix with, but the on-off over on the next side there is very perplexing. There's a sudden return of symptoms. It can be minutes to hours, and we're unsure of the cause, so there's not an easy fix for this. with this, there's enough drug available, just it's not working for some reason. And some ways that people hope to deal with this is avoid taking the drug with the high protein meal. Some think shortening the dosing interval helps, but we know that it's hard to know because it's supposed to be a therapeutic effect when this is happening. So adding a direct acting dopamine receptor agonist can also maybe help with this. But the main point of this slide that you need to remember is that with wearing off, the fix is shortening the dosing interval. So instead of taking it every 6 hours, you need to take it every 4 or 5 hours. That's something to remember. Okay, neuroleptic malignant syndrome. That's a big concern seen with antipsychotics. Stopping levodopa causes this because there's not enough dopamine in the neural synapses. And the patient, why would they do this is they can get tired of the side effects because it's taking so long to get going, and they just stop taking it, or maybe their dementia or cognitive symptoms are increasing, so they need help remembering to take the levodopa. So that means you're going to need to teach the family to watch out for these cognitive symptoms or increasing dementia and help them provide increased adherence to taking their meds. Muscle rigidity is severe with neuroleptic malignant syndrome, and it causes the shivering, which causes an increase in body temp. You need to treat the symptoms. So like if they're having fever, you'd give acetaminophen, you'd give dantrolene to relax the muscles that are rigid. If they're having dehydration issues or blood pressure, you're going to give fluids. So adding a dopamine agonist to directly activate the dopamine receptors is a way to help, and this can be a life-threatening complication. So the first drug we're going to talk about is a dopamine receptor agonist, pramipexole or Mirapex. This is the first-line direct activating dopamine receptor agonist. Okay, so that means it's going to get more dopamine across. It's recommended for younger patients because it has an increased risk of hallucinations, and this increases as the patient gets older. So also an increased risk of orthostatic hypertension. So younger patients can deal better with these two kinds of things. The advantages are it is easier to give. There's no toxic metabolites, there's no competition for absorption, and there's fewer long-term failures. As initial treatment, it can delay the onset of dyskinesias by delaying the start of levodopa therapy. And then it also appears to have beneficial effects on non-motor symptoms like depression, and it may improve treatment-resistant tremor, and also anhedonia, which is a lack of ability to feel pleasure, and weight loss. So that one might be good for the fine tremors. Adding it is a good thing for fine tremors. Possibly. So the other thing is the disadvantages here, that there's more frequent hallucinations, there's daytime sleepiness, there's sleep attacks, there's orthostatic hypertension. So all of those things, again, for a younger patient, not so bad, but for older patients, not tolerable. Okay, so benzotropine or cogentin, this drug counters acetylcholine. It's a cholinergic antagonist. It's used to treat dystonia seen with antipsychotics. It is not good for the elderly. It can increase your risk for dementia, increase confusion, dry mouth, urinary retention, tachycardia. So it's effective for tremors. That's the important thing I wanted to tell you about benzotropine, to remember that adding this in can help with the fine tremors more than that. What did I tell you before, the pramipexole? So this is the important one to add for tremors, but not maybe so good for the rest of the full spectrum of Parkinson's. So this is one like you would add it to help with somebody who's already on Sinemet and is having trouble with fine tremors, but you don't want to increase the Sinemet dose because you're in that fine treatment versus side effects zone. Okay, so interactions. With other ACH drugs, you'll have increased acetylcholine effects. So tricyclic antidepressants, some antipsychotics, first generation anticholinergics like diphenhydramine. We know that those anticholinergics are not recommended for the elderly. in the first place they're on the Beers list or the possibly inappropriate medications list. Older folks can't tolerate those kinds of drugs as well. And I think that's all on that one. Okay, so other drugs to use are amantadine or Simitril, which is an antiviral, but it also increases or releases the reuptake of dopamine. It tells the neurons to let more dopamine out, so it increases the release of dopamine, and it tells the neuron not to take it back up out of the synapse, so that's the reuptake blocking. So it has short-term effects because it only works for about 3 to 6 months. It's not a good long-term fix. It might help also with dyskinesias. The downside is that it exacerbates psychosis. Dopamine is increased, but that also can increase psychotic issues or suicidal ideation. So that's not good. And entacapone or Comtan is a COMT inhibitor. Remember, this is the second way we were talking about levodopa is metabolized to an inactive drug. So if you inhibit this metabolizing of dopamine, you increase the dopamine level. This is effective possibly for the on-off effects. Of course, we still don't know what those are from, so it might be helpful. It's similar to carbidopa, and it doesn't have anything to do at all with fixing Parkinson's. It is just increasing the dopamine by inhibiting the COMT, the metabolism, purely metabolism on the part of that drug. Okay, so we're gonna take a little break here, and we'll start up with Alzheimer's in a few minutes. Thank you.